Hello and a very warm welcome to the second day of the ISNTD Festival, the annual event by the International Society for Neglected Tropical Diseases, bringing together all things creative and the fields of tropical and infectious diseases and exploring some exciting, original, innovative ways in which to engage, communicate, share everything about these sometimes very complex tropical diseases. So thank you for being here this morning. Without any further delay, I'll kickstart this second day, day 2 of ISNTD Festival with this wonderful panel on community engagement. What do we mean by communities? Well, in this context, we are looking at it from a large number of perspectives through very different lens, whether that be engaging local communities in order to share information awareness about diseases, whether that is to engage communities into a research process, but also communities as wide as a global audience and trying to raise awareness for these neglected or understudied diseases. So how do we do that? Why do we do that? And what are examples of some great projects in this arena? That's a lot of questions that we're going to try and unpack over the next 90 minutes with our wonderful speakers. It's my pleasure to welcome you to kickstart off the second day. I'll just go around my screen in order of how I can see you. So a very warm welcome to you, Dr. Lauren Welburn. Thank you for joining us. You are with the Big Data Institute at the Nuffield Department of Population Health, University of Oxford. Thank you for being here. We also have Dr. Gabrielle Thompson, your communications officer at the University of Edinburgh and at the TIBA partnership. Welcome, Gabrielle. Thanks for being here. Next on my screen is Dr. Hang Nguyen. Hi, Hang.
Hi, everyone. Nice to see you today.
Thanks for being here. You're with the Oxford University Clinical Research Unit in Vietnam. I'm also very proud to say you're one of the ISNTD Science Communication interns. Thanks for being here. And we're also joined by Dr. Yahya Disu. Welcome, Yahya.
Thank you. Good morning. Thank you for having me.
Thank you so much for being here. You're head of communications at the Nigeria CDC Center for Disease Control. It's a real pleasure to welcome you today.
Thank you.
Thank you all. And to our audience, who's very kindly joined us as well. Before I move on to the audience, and connecting on screen, we are also joined and very pleased to welcome Dr. Stéphanie Meyer. Stephanie, welcome.
Hello, thank you. Sorry, I had connection issue, but no, it's okay.
It was perfectly timed, actually, for your introduction. So it was like a grand entrance. You're joining us from Valneva, and you'll be talking to us a little bit more about engaging communities or a global audience around chikungunya. So welcome to the panel.
Thank you.
And also very warm welcome to our audience. Please, by all means, jump into the chat. Tell us where you're connecting from, which country, organization, and any comments, questions, or if you want to share something about your very own projects, please don't hesitate to keep posting that as we go along throughout this session over the next hour and a half. So without any further delay, let's jump right in. Our first speaker will be Gabrielle Thompson. Gabrielle, you're going to talk to us about a really exciting comic book. It's only just been launched, Mission Bilharzia 101. So without any further delay, I'll hand over the floor to you to tell us all about this project, what it is, what is your audience, and what are the aims that it's trying to reach. Thanks for being here. Over to you.
Thank you. So good morning, everyone. So I'm the research communications lead for TIBA and PIG, and the comic book that I'll be talking about today was launched not so long ago in Tanzania at TIBA's Affected Voices meeting, and I'll talk a bit about that later. So a bit about the background. The comic book focuses on Bilharzia, which is a public health concern in many African countries. TIBA and PIG have done a lot of work on neglected tropical diseases and have especially focused on Bilharzia, which has led to many trips to Zimbabwe, doing field work and looking at cases and into treating it and helping manage it. We believe that in order for there to be a reduction in Bilharzia cases, we need to bridge the gap between scientific knowledge and the lay public. That way, they have the tools to be able to understand Bilharzia and what they should do about it. And the best way for them to grasp that knowledge is through relatable contexts, engaging stories, and aesthetically pleasing visuals. And we felt that a comic book could encompass this and ultimately increase health literacy around Bilharzia. So school children or school-going children are the primary target audience for the comic. However, it can also be given to adults and be just as effective. Children often contract Bilharzia by playing and swimming in the water, hence the image of the kid playing in the water there. The comic book is also within an African context. The characters, the imagery, and certain scenarios are things that can be understood by people who live in Africa. And having a relevant context will allow African readers to better grasp concepts that they can apply to their real life. The aim of the comic book is for the reader to recognize signs and symptoms of Bilharzia, the causes and prevention, and the course of treatment and who should be treating them. And knowing all of this can influence a behavioral change. For example, them staying away from contaminated water, or knowing who to approach when they notice signs of Bilharzia. And then the goal of the comic book is to print more. We were able to distribute some in Tanzania, but we want to go beyond this and actually distribute them to schools. The plan is for it to start in Zimbabwe and then possibly think about other African countries. And in order for us to reach a wider audience, it needs to be translated into more languages. So far, the comic book has been translated into English, Shona, and Swahili. And to meet these three goals, we need more funding. So that is what we've been looking for at the moment. And if we're able to meet the previously mentioned goals, we would also like to create comics for other NTDs. And then with the target audience and aim in mind, we had to get someone who could apply all of this through visuals. So we hired Masodi Kapanya, and he's a leading artist in Tanzania and works on various forms of media. His cartoonist artwork is particularly well known, and therefore he was asked to help with the Mission Bilharzia book. He decided to join us for our Affected Voices meeting in Tanzania, where we essentially had NTD affected individuals talk about their experience with their disease. At the same time, we launched the comic book, and you'll notice on the top left of the screen some of the themes he noticed around NTDs during that meeting, and he actually drew them. So he's a very talented artist who is able to capture the socio-economic issues around NTDs very well. So I want to provide a synopsis of the comic book so you can kind of understand the themes that I'll be delving into a bit better. The story of Mission Bilharzia revolves around a group of children who innocently play in water contaminated with certain snails carrying schistosomes, leading them to develop symptoms of Bilharzia. Thereafter, suspicions of witchcraft arise as the cause of the outbreak in the community. However, Lady Tata, an African hero, intervenes and dispels these misconceptions, urging the community to seek medical help instead. She takes them to the hospital where they undergo tests for Bilharzia and receive appropriate treatment. Lady Tata also takes the opportunity to educate them about the disease, empowering them with knowledge for the future. So obviously this comic book tells a story, but is also very informative. The first page of the comic book shows the first point of contraction. So children are playing in the water, but they don't know that the Lake Limpapa is contaminated. And they're also in a village and a remote area, which is often where you'll find a higher burden of Bilharzia. And then as a result of these kids swimming in the contaminated water, they begin presenting signs and symptoms of Bilharzia. One of the characters notices his son vomiting and seeing blood in his stool. Someone else's child in the village also presents similar signs. And the common denominator is them all being in the contaminated water. And when the son starts presenting signs of Bilharzia, the father is not able to recognize what he is suffering from. So he automatically thinks his son has been bewitched. And certain African communities and individuals believe in witchcraft, and bewitching is sometimes the only way that they can justify their illness. However, if they were given the knowledge to recognize Bilharzia, being bewitched is not the first thing that would come to mind. So therefore, the gap in knowledge is leading people to seek help from a traditional healer as opposed to a professional health worker. And then when Lady Tata eventually appears, she emphasized the importance of prioritizing health. While the distance to get to some of the clinics and hospitals from remote villages can be very far, not treating their diseases will not stop the signs and symptoms. And obviously not prioritizing their health can impact other areas of their life. So Lady Tata can also be seen as a figure that represents community health workers. They're usually the primary contact for people in remote villages when they're noticing signs and symptoms of illnesses, and are often trusted members of the community who can then guide them to the next course of action. The comic also prepares the reader for what is expected if they go to a clinic or a hospital. They are often expected to take a urine sample, and then if they have tested positive for Bilharzia, they will receive some pills, which is usually praziquantel. Having no idea of what to expect can create fear and anxiety. So having this prior knowledge that the sample and the treatment can help them is necessary and safe, can put them at ease if they're ever in this sort of situation. And then lastly, we have the causes and prevention. So Lady Tata, towards the end of the book, now clarifies the cause of Bilharzia and misconceptions around it. She also provides an example of farmers using a bridge to avoid being in contact with contaminated water as a way to prevent them from contracting Bilharzia. And therefore, all the themes presented in the book are also tools for people to take away with them. And so what Mission Bilharzia does is effectively educate school-going children about the signs, symptoms, causes, prevention, and treatment of Bilharzia through a compelling comic format. By distributing this comic in schools, more children in Africa can learn about this public health concern and take preventive measures, bridging the gap between scientific knowledge and the lay public, while also increasing health literacy in the community. The comic book intervention in dispelling misconceptions and promoting medical help showcases the importance of accurate information and behavioral change in addressing health issues. I would like to quickly acknowledge the University of Edinburgh Parasite Immunology Group, the Scottish Funding Council and TIBA, and also the various people who contributed to the comic book. And if you guys would like to view it digitally, we have the QR code there for you to access it. And yeah, thank you all for your time.
Thank you, Gabrielle. What a great start to this session. A really exciting and recently launched resource, and we look forward to seeing where it goes next in terms of whether that be translations or it being distributed across more and more regions. Thank you for that. And also a great way to really highlight and give a much bigger platform to some very established African creators. Masudi Kipanya, lovely to see the artwork kind of highlighted and shared more widely. So thank you for that. We're going to move from the very local engagement to kind of a broader arena, global audience. And so our next two speakers are going to share with us some insight into the challenges, but also some of the strategies, some of the ways in which to communicate on health risks, on specific health risks to a much wider audience. And so I hope that the connection will be on our side. Dr. Yahya Disu, we would love to hand over to you now. You recently published a paper that looked specifically at risk communication during health emergencies in Nigeria. What are the challenges? And so if it's okay with you, if your connection's okay now, I'd love to hand over the floor and listen to some of the advice you have to share with us.
Okay, thank you. I'm still having issues with my connection. I wouldn't mind if the next speaker can go ahead while I sort this out. Otherwise, I have to present from my phone. I'm speaking from my phone now.
Okay.
So if you give me a chance, yes, so that I can use my slide. Thank you.
Absolutely, thank you. Sorry, because this is meant to be a relaxing experience and not a technological headache. So sorry about that.
Okay, but if you want me to go ahead and speak or through my phone, that would be fine. Not necessarily to use slide.
We've got a few minutes, so if that's okay with you, we'll swap to Stephanie and then we'll come back to you after or whenever you're settled.
All right, okay, that's fine. Okay.
Thank you.
Okay, thank you. So you can move to the next speaker.
Perfect. Great. Well, that's your cue, Stephanie. We look forward to hearing all about your challenges and how you're communicating about chikungunya.
Thank you, Marianne. First of all, I would like to thank you all for giving me the opportunity to take part to this session on challenges of raising awareness on unknown disease. And raising awareness is the first key step that we have to handle to fight against this new disease. So the challenges of raising awareness on chikungunya starts already when you pronounce the name of the disease. And when you have to spell it, it's even more difficult. Chikun what? This is really the first reaction that I hear when people ask me what I'm working about. Then people say they never heard about it, and I wonder if this new disease is about chicken. Is this a new disease that is being transmitted by chicken? Is it related to chicken? And not at all. So this is really why we need to do a lot to raise disease awareness about the disease. So how is the virus transmitted? You know these two mosquitoes, the Aedes aegypti and Aedes albopictus mosquito that transmit dengue, but they also transmit chikungunya. And in the fight against CHIKV, these mosquitoes are also our enemies. The virus is transmitted following the bite of infected mosquitoes, and it has not been very well known because it has spread recently only to other countries. So the disease chikungunya is derived from the Kimakonde language and not at all related to chicken. And it means in Kimakonde language to become contorted, which is really the stooped appearance of people that got the disease and that experience arthralgia, which is one of the main symptoms of the disease. Few words about the disease. First, the disease has different stages. The first one being the acute stage that develops in around 75% of individuals who will be infected by the virus. The symptoms usually occur within 3 to 7 days after being bitten by an infected mosquito and are characterized by sudden onset of high fever and joint pain. But you can also have other symptoms which are not really specific, as you can see, which can be headache, muscle pain, red eyes, nausea, vomiting, or rash. So this is also why it's difficult to know more about chikungunya, because there is often misdiagnosis and the symptoms are not that specific. So if you rely only on clinical diagnosis, you can underreport the number of cases. The symptoms usually resolve within 7 to 10 days, and there is no treatment against the disease. It's really a palliative treatment that is implemented. So it resolves within 7 to 10 days if you are lucky, because we have around 33% of individuals who will develop the chronic phase of the disease, which is really where the morbidity of the disease is. And this is why we should really take care about the disease, because chronic phase will end up in debilitating impact that will have an impact on day-to-day activities. Indeed, those who will experience chronic disease will often experience arthritis that can last from months to years. They will have difficulty in raising from a chair, for example, opening up a bottle, picking up objects, and this really has an impact also on their day-to-day activities, but can also have an economic impact when there is a chikungunya virus outbreaks. So this is really why we need to do something about the disease, raise awareness so that people know about the disease, know that arthritis is not only related to other disease, but can also be due to chikungunya, and we really need to know more about this disease. So the disease has been identified in 1952 in Tanzania during an outbreak, and this is where the word chikungunya comes from, because of the stooped appearance of those who experience chikungunya. And as you can see here on the map, during the first decades after its discovery, outbreaks were really limited to Africa and Southeast Asia, and we did not hear a lot about this. Moving to later on, we can see that up to 2005, there were still outbreaks in Africa and in Southeast Asia, but again, these were limited in duration, limited in the number of cases, and as we didn't know a lot about it, we didn't talk a lot about it. Starting in 2005, there were a change in the virus that had the viral mutation, which allowed enhanced fitness to the albopictus mosquito. And this is how the virus really spread. We can see that there were much more outbreaks that were much more intense. And we can see as well that starting with this mutation, the virus really spread across the world, with cases that have been reported in the Americas as well, in the US, but also in Europe, with an outbreak that occurred in Italy, following the importation of one single case from someone who traveled back from India and who was infected by the virus. With susceptibility of the population and presence of the vector, this led as well to outbreak locally in areas where the disease had never been seen before. And we can see that the virus continues to spread, with a huge outbreak that took place as well last year in Paraguay, with more than 140,000 cases that were reported. This year in Brazil, we already had more than 100 cases that were reported as well. And we know that with global warming and climate change, this will further drive the rise of CHIKV vector habitats, and the virus will continue to expand. So there is really a need for the entire scientific and medical community to be aware about the disease, to know more about the disease, because there are still many unknown. We do not know a lot about what is really behind the chronicity of the disease. There is still a lot to be done in terms of reporting as well, because as the awareness is not that high, people do not always think about chikungunya when they are diagnosing. So what are we doing at Valneva to raise disease awareness? Because this is really a key element to build a bridge between the scientific community and those facing the disease. We need to increase the level of disease awareness. We need to know more about the consequences of the disease. We need to see as well how we could increase the way surveillance systems are implemented so that we can better define risk areas and know more about where are the risk of getting the disease. We need to work as well with other companies to develop more diagnostic tests, because there is a lack of rapid diagnostic tests, which really leads as well to underreporting and misdiagnosis. And we need to know more about the economic burden of CHIKV, because this is not well established so far. And this is all the event that will be needed so that people really want to take care, I would say, to take care about the disease. So far, we are really involved at the HCP level at Valneva, building partnership with medical societies to spread the word about chikungunya. We are also involved in developing medical education so that the medical community knows more about the disease, where to find it, why to think about it when they see people suffering from arthritis or for joint pain and so on. We partner with some Medscape company to spread the word about disease. We participate to congresses to have education symposia about the disease. We've developed some videos to see how the disease is being spread, how the symptoms are being developed, and how the disease appears in several areas of the world. So we do some assets like that so that this can be shown and help educate the HCPs. We are in close contact as well with some patients to have patient testimony so that we can really see as well what is the impact on people's life to be infected by this disease. Related to the previous talk that we just had, we are trying as well to develop some comics so that we can show what is the disease in something that is quite easy to understand and a bit funny as well, so that we can attract people to see really what are the consequences of the disease, so that we work all together then to spread the word and to tell people what is about the disease and how we can also fight against the disease. So this is what we are doing with the HCP. But in addition to that, it's also very important to maintain a dialogue with all relevant stakeholders beyond the HCPs, including policymakers and NGOs, to ensure that the risks from chikungunya are well understood and that actions can be aligned and globally aligned, such as improved diagnosis and reporting, which is really something we are lacking so far. So directly and indirectly with Valneva and Instituto Butantan, which is our partner in Brazil, we have engaged with governments such as the Ministry of Health or Science, international organizations as well, such as the European Commission and its Directorate General HERA for Health Emergency Preparedness and Response Agency, to really see how we can spread the word about that. We organized some events at the European Parliament to inform the stakeholders about the outbreak diseases in general, but also focusing on chikungunya in particular, so that people are aware that there is a risk and that we should be prepared and do something about that. And we joined an event organized by ISNTD last year on tropical diseases at the UK Parliament, so that awareness is also there in non-tropical areas. We are partnering with CEPI as well, who is supporting us in all our activities. And as mentioned, we partner with scientific societies and with International Vaccines Institute, taking part to global stakeholder meetings to really spread the word about Chik virus, recent outbreak, vaccine development, and the way forward in order to have a joint effort with all the stakeholders to be able to fight against this disease. Today, we are really grateful to ISNTD for having us invited to this event, as to us, this presentation is also a way to spread the word about chikungunya, about what is the disease. And we are really looking as well for people on the call who would like to collaborate with us to know more about surveillance, all the gaps that we still have to fill in order to be able to know more within the scientific community, but also to bring and to spread the word to the community who is suffering and facing the disease. So the policy areas we are advocating for are related to disease awareness, improving epidemiological understanding of past and present outbreaks, and also possible mitigation that are being considered, a task that we will further work on. So again, these are really the gaps that we are looking for and that we need to fill regarding surveillance, seroprevalence, better understanding of the course of the disease as well, diagnosis to increase access to diagnosis, know more about outbreak prediction because chikungunya so far is really something that is unpredictable. We know that there will be outbreaks, but we don't know when, we don't know how, and really educating people in the scientific community, but also those who are facing the disease. These are really all the challenges we are trying to take one after the others, and we need really an integrated approach to spread the word about that. Thanks a lot. We are sure that together we can make this happen, but we are really looking to work all together for that purpose.
Wow, thank you so much, Stéphanie. Certainly a lot of knowledge gaps and the road ahead, as you say, is long, but very impressed and interested to hear about all these extremely multifaceted approaches that you are putting out within a huge range of stakeholders and partners and audiences. Really interesting to hear you're thinking of a comic book as well. This seems to be an approach adopted increasingly throughout neglected tropical diseases. So we look forward to hearing more about that in future. Thank you for sharing this. And I think just on cue and just on time, Dr. Disu.
I think I count this as a privilege to be invited to such a forum to share my experience of the work that we did in Nigeria as we published recently. I'm actually the head of risk communication and community engagement in Nigeria. And we've been responding to public health emergencies. The major ones, 2014, the Ebola outbreak. I worked in risk communication then. Then in 2019, 20, 21, COVID-19, Lassa fever, mpox, yellow fever, and so on. So those are what we, the experience that we had. But COVID-19 is the most recent one. And there was a lot that we learned from COVID-19. Just to give us background of Nigeria, I was going to cope with this. So, but largely, our response was adaptive. It's in the context we respond to several diseases, mpox, Lassa fever, yellow fever, and then COVID-19, and also Ebola. And Nigeria Center for Disease Control has the responsibility or the mandate to lead response, prevention and response to those infectious diseases. So COVID-19 was the most recent one that we learned so much from. And we all need our communication evolved, and then our messaging was dynamic. We will continue to do polling and also integrate this with focus group discussion from community, and then they also look at it based on context. So the current challenges are categorized: health emergency related challenges, the population vulnerability, and the health system resilience. For the health emergency related, the significance of the public health emergency by its morbidity, mortality, and is very key. And then if it has high morbidity, mortality, then it is certain things we expect, like infodemics, which will accompany that. And also sometimes we can volatility or uncertainty and problem. And then ambiguity, like COVID-19, the initial phase of COVID-19, when we did not have understanding of clear mode of transmission and the source of the problem. So, but over time, we were able to get about it. So these are challenges we encountered. For population related, the cognitive vulnerability, low literacy, low health literacy in particular, and low e-health literacy. People who are not able to utilize the digital system to access information, process and understand it. And then, so that is a challenge. Then the emotional vulnerability coming from the widespread panic, anxiety, and then sometimes we also move into the apathetic mood where people are not even responding to our interventions. Then the psychosocial, looking at how people relate to their people, how their relationship affects the decision they make. So we use sociological model in planning our communication intervention. And then we also use that not just with ecological model, EPPM model, expanded parallel processing model, because to be able to moderate the fair dose in our messaging, and we continue to adjust it based on how things evolve. And also the health system itself, challenges with coordination, especially at the subnational level. At national level, we seem to get it right because we had existing National Risk Communication Technical Working Group that have been meeting regularly. We're able to adapt our multi-hazard guideline to reflect the context of COVID-19. So we had a document developed called the RCC Strategy for COVID-19 Containment. But at subnational level, it was a huge challenge for us. Then the resource constraints. We need resources to be able to mobilize the community, and then to be able to do the airing of jingles, and also expertise that are needed in delivering the healthcare services. Those are challenges. Even the materials to be used, these are issues. And then data availability. We had limitation. Can you still hear me? Hello?
Yes, absolutely. Yeah.
Okay. Data availability was another major challenge because the way our system is structured, we collect data from community health facilities, it moves to states, then from states to the national. Sometimes you have poor quality data collection and poor quality in the collection of the data, the way they process the data, or sometimes delay in transmitting the data. And that affects the way authorities can process and then communicate to the public as to the updates on concerning the emergency. But we had a digitized system in Nigeria, we call it SOMAS, that's used to collect electronic data and then transmit it. But many states were not doing that before the COVID-19 pandemic. But before the pandemic, with the end of 2020, many states got on board and they roll out these SOMAS. So we are able to overcome that challenge. But then there is also issue of clinical data, which has to do with various strains of this COVID-19 coming up and how do they present. Because we are having few cases in our environment, we're not able to describe it the way they have experienced it in the developed world. So and then the perception data, and we launch opinion polls. We are doing perception surveys regularly to understand how people are thinking, knowledge gap, and also address misconception. And then community engagement, focus group discussion are also conducted at the community level. So triangulating all this data, we're able to get insight as to how to adapt their messaging and our intervention. And the political context is also very key in terms of the political difference now. Some state governors will tell you there is no COVID-19, it's a scam, and that is going to affect how they are going to respond in their state. And that information filters to other states that their governors agree that there is COVID-19. So there's huge confusion with regards to authenticity or whether this is real or not. And without good political commitment, resources will not be mobilized or prioritized for this. Then the environment, some live in the rural environments, some live in difficult to reach areas, and which makes it difficult for us to get information and our intervention to where they are. Some, it could be infrastructures they could not access, and then so some live in urban center who have access to digital information, and which also create further disparity. Those people who have low socioeconomic status, they are not able to access information like those who have high socioeconomic status. So those are things that we have to consider in the planning our intervention and adapting our intervention. Also, the legal is also part of that. Some their rights are being infringed because of the lockdown, and then so a lot of confusion coming from there. But then the public authority will say, we are here to safeguard the health of the populace. So, wow, so that's a huge challenge there. Now, this is just to show you some of those challenges that we face. Then we also did another study. Part of the study we continue to do to understand how people are responding during the emergency, during the COVID-19 pandemic, the lockdown in particular, how lockdown has affected access to medication, access to money, and access to food. Then this is just a slide that shows how all those installations put together, personal communication, media engagement, regional collaboration, constituency relations, working with various stakeholders like health workers association, professional bodies, even the private sector. There was a partnership that was formed to mobilize resources and also pass our messages across them. So these are some of the materials. We use jingles, we use the audio and video jingles, we use community drama. When you say drama, it is something some people acted and then they started disseminating that to the community. But when the lockdown went for the COVID-19 vaccination, we're able to also get some volunteers in the community who are able to disseminate information in the community. And so this is more of the, so I'm coming to, of course, this is from one of the weekly opinion polls results that we were doing there and to inform our messaging. And then also, this is a dashboard for the weekly opinion polls, one of the dashboards that we use to inform decision. Presidential task force, they were also using this to inform decision. So the key thing we have learned from this is use of data is very key, and then engaging anthropologists, sociologists, and to also bring in their expertise in understanding the community drivers of behavior and why people want to take our advice is very key. So we are learning that, and we're having more collaboration with those now to even make sure that our planning is research-based, understanding community characteristics, the population, and also then the intervention. Of course, media engagement. As a result of that, we launched a media media fellowship program because we realized that media were contributing to the infodemics. Though they are still the reliable source of information compared to the digital media. And so now we have vanguards who can understand science information and interpret it, and then also communicate in a way that can affect behavior change. We call it media EIS. The content includes epidemiology, infodemic management, and social behavior change communication. So these are some of the challenges, some of the interventions that we put in place to be able to achieve what we achieve. Thank you very much. I think I'll wait for a question session. Over.
Thank you so much, and thank you for your patience to connect with our event and our audience. Wonderful presentation and so many insights. And so Hang's going to speak to us again. We're looking at all the different ways and to engage communities, and one of the ones which really we felt is sometimes not spoken about enough, and your work in this field's really interesting and exciting. It's about engaging medical students themselves into the into NTDs, into this process of understanding and learning more about them. And so Dr. Hang Nguyen, you've been working at OCRU on a project looking at healthcare students' voice in ethics and clinical research, particularly around dengue. So the floor is yours. We have much to learn, I think, from what you've been doing.
Thank you, everyone, for having me today. So I'm Hang Nguyen from Vietnam, and currently I'm working as a research assistant at Oxford University Clinical Research Unit and an intern of the ISNTD. Today, I would like to share with you about our research to explore the healthcare student views about ethics and clinical trial, which we use the mixed method in public engagement and social science techniques. Through the research, we want to promote the young people's voice and their contribution in healthcare programs. This presentation will focus on our experiences in facilitating engagement activity with students and how we could help to enhance the involvement of young people or the community in health research. This is my disclaimer for my personal opinions and information in the presentation. We will go through three main parts of the presentation, which are the introduction and the methods of the research project, the research evaluation for the Vietnamese cohort after 3 years, and finally, the research expansion to other countries with our challenges. So research project is the joint research of Oxford University Clinical Research Unit and the University of Medicine and Pharmacy at Ho Chi Minh City, the most crowded city in Vietnam, in exploring attitude to research involving human subjects among Vietnamese healthcare students from 2019 to 2023. The research topic focused on medical and public health student attitudes about clinical research and human challenge study in dengue, which is a very novel type of research and hasn't been conducted in Vietnam. We explore their acceptability, risks and benefit perception, financial consideration related to compensation when joining clinical trials, and other ethical issues in implementing trials. We use the mixed method in the research, which comprise two components. First is a public engagement part with about 48 activities where students could openly discuss a wide range of topics related to clinical research, namely science cafe, debates, role play. We have poster, video competition, or social media campaigns with support from groups of student ambassadors. Along the public engagement activities, we further explore in detail student attitudes by using social science tools such as surveys, focus group discussion, and in-depth interviews. For more information in the methodology, you can read our published paper here. I will send the link later. After 3 years of research, we conducted an evaluation for all of our activities with the Vietnamese cohort of about more than 500 students. The purpose was to explore participant experience during the research. We apply again the mixed method to map the journey of the student at the end of the project. with 18 in-depth interviews, more than 200 completion forms. In addition, the evaluation also included a big number of feedback forms which were collected after every engagement event through 3 years. The factors evaluated including the student motivation to join the research, their experiences during their participation, their evaluation toward our organizational factors to identify any difficulties and barriers during the participation, and finally, the benefits that they found meaningful to them. We summarized the Vietnamese student journey in the Research Seed project in this map. To begin with, you can see in the left side of the slide is we start with the student demand and interest in having more knowledge about research and medicine, improving soft skill and networking opportunity when joining the extracurricular activities. The project meet the demands and raise student curiosity with a well-prepared opening introduction section that motivated students to join the project. Along the period, there were many encouragement factors for student retention by bringing them positive experiences and gradually improving our activities. The students found their participation had many benefits which met their expectation at the beginning. Especially many students were inspired to do research in the future. However, there were also many barriers and difficulties preventing them from participating, such as the busy studying schedule of healthcare students, difficulties in expressing their ideas during the discussion, low interactive activities, or the interruption of COVID-19 pandemic when we had to conduct most events online. From the evaluation, the students suggested many ideas for improvement. Here are the general themes. First, it is necessary to consider the compatibility between the student demands and our research topic or goals that can bring the benefit for both sides. Then, to promote participant involvement in the research, we have to work and find out more and more interactive approaches, considering factors such as the platform we use online or offline, how the format we use for engagement activities. Along the process, we also should regularly evaluate to detect and address participant difficulties and barriers, which are sometimes very specific to different groups of subjects. Here we have the example of busy schedule of healthcare students is the most significant one. In addition, participants need to well perceive by being shown or reminded them about their roles and contribution to the research, which make them know their work is meaningful, therefore remain their retention in a long period of time. Last but not least, it's important to promote research communication with the participants on social media, which is now very popular with young people, which we can optimize by having support from student ambassador. And by that, we explore the potential and creativity of young people in how they can make the science become more interesting, familiar, and approachable to a larger community. You can see here the example of communication products that created by our student and student ambassador through poster and videos competition or social media campaign to engage with more people. Based on our research with the Vietnamese student, we expanded the research and plan to apply the same method with medical students in other countries to explore the cross-cultural differences in attitude to human challenge study. However, due to many challenges, we were only able to conduct a part of collecting online surveys with the support from international student ambassador from Singapore, Malaysia, Nepal, Palestine, Pakistan, Taiwan, and Australia. Conducting multiple country research faces many challenges. First, we want to mention the organizational factors. First is very important and may take a lot of time for ethics and university approval and support at research site. The process requires a great involvement of the local ambassador. Here were our students among countries and their influence in how much they can facilitate the data collection effectively and also the engagement activity. Because the distance, we have to conduct own events online, which impacts a lot in how we can optimizing engagement approaches. In addition, the language barriers or the difference in time zones particularly make it difficult to conduct engagement activities for all the participants. Secondly, there are human factors which require a lot of discussion between the research team and the local ambassadors about the local student motivation and their willingness to participate in our research. It can be very different in countries with different economic status or available research opportunity for students in the school that affects in how they want to join in with us. The balance between compensation when participating research activities, even when they take time to complete our surveys, compared with student time commitment and their time budget. And finally, we also need to consider the differences in level of knowledge and understanding of students related to health, disease, research to make sure the student can join the activities reasonably. By sharing our experience with students in the project, we hope that we can contribute to enhancing and improving the approaches that we use for health research, implementation, and public engagement activities with young people and the community. I want to thank the great effort of our research team at OCRU, of the student ambassador at research site, and all the students participating in our research, and of course our sponsor that come from University of Oxford and Wellcome Trust. Thank you for listening, and please feel free to contact me for any further information.
Thank you so much, Hang. That was a really important, fascinating approach and angle. The medical and scientific students, the next generation of advocates for these diseases, it's really important to engage them more and to understand and improve their attitudes to research. So it's been a really great insight there, and fascinating to see this interplay and kind of the intersect between public health, research, bioethics even, and how to integrate social sciences a lot more into public health and to engage with this really important stakeholder, which is the next generation of researchers. So thank you. Often it's kind of a new, growing and novel area and field of study. So we look forward to hearing more from that. Well, we haven't been able to have Dr. Yahya back on the call, so we'll hop to our final speaker for the session. Hi, Lauren. Lauren Wilburn, you're with the Big Data Institute at the University of Oxford. You're going to share another really exciting project about engaging communities and having feedback to improve the study designs, the development of research, and with examples from SchistoTrack. So thank you for being here with us, and the floor is yours.
Yeah, thank you for having me. I'll just share my screen now. And is that working okay?
Yeah, that's perfect. Thank you very much, Lauren.
Yeah. So, good morning. Today I'm just going to talk a little bit more about how community engagement can be used to actively improve studies. So I'm here on behalf of the Schistotrack team based at the Big Data Institute in Oxford. And this work has also been heavily supported by the Ugandan Ministry of Health, especially Betty Nabate and Dr. Narcis Katarina. So just a little bit of an introduction to the cohort. So this is based in 3 distinct regions of rural Uganda. There's over 4,500 individuals that are clinically assessed every year in January so far, the first one being 2022. And the main outcome that we're assessing is the liver fibrosis associated with schistosoma mannsoni. And on the right, you can just see just an ultrasound image of kind of one of the worst stages of this fibrosis. However, there's lots of other co-infections that are also tracked as well that might also contribute to this fibrosis. So one of the things, especially with a longitudinal cohort study, is to keep participants actively engaged. So before the study started, all the community engagements had been integrated into the planning. So back in December 2023, there was district level and village level community engagement. And today I'm just going to talk a bit more about the village level engagement. So within teams went to villages. There were about 4 or 5 villages invited to a local centre. These included study participants, family members of study participants, for example, parents, carers, also Ugandan Ministry of Health representatives. For example, the programme manager for Bilharzia and worm control attended with us to answer more complex questions to do with mass drug administration. There was also Schistotrack key members from the Ministry of Health, including the head mobiliser that had formed relationships with the communities, and also the programme manager of Schistotrack, Betty Nabate. There was district NTD focal people and local village leaders and local health workers also attended. The overall structure of this meeting was opening remarks by the village chairman, schistosomiasis health education by the district and neglected tropical disease focal people. We then went through and fed back village level results. And this includes the schistosomiasis prevalence, the hepatitis prevalence, malaria, and we also took this opportunity to highlight a link between schistosoma mannsoni infection and HIV that I'll touch on a little bit more in a second. We also really stressed to communities that we wanted feedback, questions and explanations about these results. What was their opinion on this? If there was a really high prevalence in one area, what did they think about this? And just to stress that the village participants were very informed about kind of the landscape of even funding for MDA in the communities, how taking your medication can suppress HIV, and how taking medications for things like malaria and schistosomiasis can improve results. So actually getting feedback from communities about these, very important to the study. We also invited local HIV counsellors to provide HIV education, sensitization, and they ran the introduction as to why we wanted to integrate HIV into the study. So this is just to justify why I'm bringing HIV into an NTD session. It's from a recently published paper from the group. We found self-reported HIV history had a strong association with liver fibrosis. So that is so important for us to actually collect accurate data on HIV, who had HIV, what HIV medications would people have been taking, and how this contributes to liver fibrosis. But HIV testing can be very sensitive. It can maybe induce stigma. So we wanted to really approach this carefully and make sure it's in a way that communities would accept this. So there's kind of like 3 main stakeholders in this. You've got your participants, the Schistotrack team, and the HIV focal people from those districts. So during community engagement, participants really stressed that if they're going to have testing, obviously they want access to treatment. So making sure that access to treatment is quickly, that people don't get lost between diagnosis and treatment is very important. Confidentiality. This is done within, these clinical tests are done within a local village. We don't want people to be singled out and for everyone else to know they have been tested for HIV. The participants are also very clear on how they wanted adults and children to be given the results. So during counselling, adults may wish to do it on their own, but maybe adults wanted to be with the children to provide support, as they're going to be providing support downstream as well. There was also a lot of emphasis on access to care for non-participants, so partners of people that may be tested on the day, maybe a home kit available for those partners of those affected. The Schistotract team wanted a standardized diagnostic for HIV to really try and assess this association between. One wanted to know about the ART regime, and actually determining what regime people around was quite difficult. There's a lot of different drugs in the area with different manufacturers. So it's not possible just to show people a picture of the drug maybe that's been used in some cases and to get feedback on that. So we really worked with the HIV focal people to develop a way of bringing the drugs that are available in the local areas to try and see what people have got. And also because HIV can be a stigmatizing topic, only collecting data what is required. There's lots of tools available, for example, from the WHO that are really detailed and great for HIV collection. But for this study, we don't need to know things like sexual history or behavior. And the HIV people really wanted these village level statistics. That helps with their own planning for future purposes. And it lets them know where to kind of concentrate the mobilization and for their own testing. They also wanted people also enrolled in care immediately. So these people are not referred to a clinic that maybe don't go later. And they also, which I think is very important, everything from the survey and diagnostics, they wanted the same as their own records, which for us also is very important. So things like following the national testing algorithm, making sure the same units are used, the same time periods are used. So say if the last two follow-up time frames are different, we really wanted to follow the local ones. So it's about how these kind of communities different stakeholders can work together to make a better study for everyone. And also just to flag, the HIV focal people are actually part of the Schistotract teams during the study period. So yes, they are workers in that district, but during the study period, they are recruited, they're on payroll by the Schistotract teams. So these kind of the relationship between really helped us understand the medication in the district, tailoring surveys to match the clinical records, allowed streamlined surveys to be relevant to both parties, and allowed us to feedback results between the HIV focal people and their teams repeatedly. We've recently just shared a big overview of what we found in January with the teams to do with hepatitis and HIV. And also by having local HIV focal people, it builds trust in communities. These are people that they will go to for care later. So developing that trust from the start was really important. So how that actually influenced our study. So this is just an overview of how patients navigate the clinical pathways. So the first thing we changed was the entry point. So based on participant feedback, we had HIV counselling. Some cases for the general sensitization, this was done in larger groups. Then for one-on-one questions, information was done one-on-one with parent and child. Then as we moved, and also, sorry, just to flag, HIV testing was completely optional and was a completely separate consent form. So patients, even if they were previously involved in the study, did not have to undergo HIV testing. And that was strongly emphasized. We then had blood tests. The blood test was taken from the same drop of blood, taken from the same finger prick as other blood tests in the study, like malaria, to reduce any extra finger pricks. It was done following the national algorithm, so these data could then be combined straight away, then be used by the HIV counsellors to get people into care immediately. Food, drink, and treatment station. So this is where referrals go on. We also got a lot of feedback during the community engagement that people wasn't finding out their results, when in fact we just neglected. We gave referrals for positive cases, but didn't explicitly say if people were negative. So this is something we really wanted to improve. So any non-HIV diagnosis that was negative was now flagged at the treatment. If you underwent hepatitis B testing, you were told you were negative at the treatment station now. And also at the exit, this was post-counselling, feedback of HIV results. And also, if you were tested positive during the day, you would be enrolled in treatment on the spot. You'd be there with the HIV counsellor, and you would start the process of undergoing HIV treatment and pathways further down. Also, there's an issue of confidentiality that we wanted to maintain. This, at the exit station now, is where we give the participants soap for being involved in the study. This was in a black bag. So then also any kind of medications that were given could also be put in a black bag to maintain this confidentiality. So just in summary, that community engagement is so important for communities to kind of gain knowledge about their health, gain knowledge about different diseases, but it's also really important for researchers and to improve your research quality, the usefulness of data and participants' experience. So yeah, in summary, community engagement is more than providing results. It can be a really, really useful research tool. And just a thanks to the study PIs, Julia and Narcis, the Oxford team, and the team in Uganda, especially Betty. Thank you very much.
Thank you, Lauren. Another brilliant way in which an innovative way to engage communities, really delving right into the way and the scope of research. And that's a theme that's kind of permeated this festival, actually. It's this intense and renewed and growing effort to ensure that at every step of the process, all the way from advocacy right into how research is designed and programs are implemented in communities, that affected persons, at-risk communities are really an integral part of that entire process. So it's been great to hear of another concrete example of that. Thank you so much. The whole session has been incredibly rich. I'm sure the audience will agree. We've gone from all the way from local and hearing about awareness building, all the way to regional, national, even international, and really building that advocacy, but also looking at research communities and how to engage those to improve research in tropical diseases. So it was a kind of a really interesting and exciting tour of all the many ways that engaging communities further into NTDs can happen, needs to happen. We do have a few minutes for questions or even comments from the audience. And that's all. Miranda Biaruranga has said wonderful presentations. Jafet Valens Pagama was saying, I'm so happy to be part of this discussion. It is really important. It's very enriching. And so I suppose one of the things that maybe we were all wondering, and perhaps you can share your viewpoints, your insights in that, for all those working in neglected tropical diseases, given the huge array of engagement strategies that we've heard from, thanks to your presentations, what would be your advice to someone who's working in tropical diseases, who wants to start somewhere? How do you first decide on your audience or your strategy, where to start really, and what guided you in your work? I don't know if someone wants to jump in and answer first, or should we go in order of presenters?
I can start. So that's a challenge to answer this question, I would say. I think what is clear is that we need really an integrated approach. But from my point of view, depending on what you are working on, I would say that it's really important to engage first with the scientific community so that they can spread the word as well. And then, you know, find people who could also go to the community with lay language and so on, because scientists used to talk with their difficult language and so on. And so I think it should be done all together. And also what is really difficult, I would say, is because we hear a lot always about new diseases, and I think there is a kind of fatigue as well. We do not want to spread bad news, I would say. So it's important as well to avoid being too dramatic when talking about that, really to have clear messages that are easy to understand, and that this has to be done all together with, taking into account all the people who would face the disease, those who would do some research, those who would care, those who would suffer from the disease, really to have something that is done together. And I would say that one of the big challenges as well is to be able to have communication that is suitable and to avoid fake news also and around all of this. And I think this is really a challenge today.
Yeah. And we'll come to that. That's really interesting to hear from you, because as you explained with chikungunya, it being a re-emerging threat, it feels like awareness, engagement on every level needs to be done. And you're clearly at Valneva doing that very well. Did anyone want to add to what Stéphanie was saying?
Okay, can I go?
Of course.
Okay, I think layering on what she said, engaging the scientific community, we propose, and that's what we do, interdisciplinary approach, getting people from different disciplines, science, anthropology, and then to work together. Lessons we learn, and it's only the community with their knowledge, with their commitment, with their understanding, and then you will be able to tackle it. So first thing is, whatever we do is science-based. Starting.
I don't know if it was just for me or everyone, but Dr. Disu's audio was quite broken. But what I did hear was just echoing what Stéphanie was saying, was the commitment to the really starting from the science. And Dr. Disu's joined back. Sorry, Dr. Disu.
Sorry,
yeah, we lost you in the middle of your comment.
Yeah.
I think you were prioritizing scientific rigor and echoing Stéphanie's comments on avoiding misinformation. Is that right?
Yes, of course. It needs to be clear to people what causes this disease and how they are transmitted and what are the preventive measures. So, and then also the use of human-centered design. That's another thing we're able to do. We piloted that in communities where we have Lassa fever. And we plan to scale that up for other diseases and also collaborate with other agencies who are dealing with other diseases. Like, for instance, this neglected tropical disease. After this now, I'm going to call the Federal Ministry of Health and say, who is in charge of this? How can we work together? Lessons we'll learn from this. In our human-centered design intervention in the community, can we also expand this to include some of these neglected tropical diseases? And because to use multi-pronged approach, and then because the important thing is to following the need to mainstream this into the health system to make sure that neglected tropical disease are not also left out. As we are looking for Lassa fever, mpox, we're also looking for schistosomiasis and some other things. And then to use data to drive whatever we do, community data, social data, epidemiological data, and then also data from perception of the people. And they can also help us in terms of designing and adapting our intervention. But not that thing that is engaging anthropologists or sociologists is to enable us to use those social and behavior change models. And that brought a lot of clarity as to what the issues are, how to design our intervention, and how to progress and monitor and measure our performance. I think that these are very key for moving forward. Thank you.
Brilliant. Some great advice and very really great to hear that coming from such a high-level position. Thank you. What else should be prioritized? Would anyone else like to add to this?
I think that in our research, it's really important to become from external to internal by having more connection with the local people, like the student ambassador in the countries that we conducted the research, because they will be the people who should be involved in the really first day when we decide how we want to collect the data, how we design the engagement activities with the local people. So I think that part is really important because we just can't come directly into the community and ask people to follow the research that we already designed, but never consider the factors that influence in how the people will link to join our research.
Mm-hmm. Very important to consider this. Thank you, Han. Gabrielle and Lauren.
Yeah, I think, sorry, do you want to go? Yeah, I think it's quite a complicated idea, even for us. Like, it's quite clear-cut on like a community, but you still have to make sure you're engaging kind of the community leaders, kind of district officers to do local advocacy, and the national level as well to actually make the changes. So I think it's about spending quite a bit of time to identify who your audience is before you even start to think about engagement.
Yes, it is complicated. That remains the fact, and it's just been wonderful to see how you, in your different projects, untangle that. Gabrielle, what about from your perspective?
I was just thinking about how effective collaborating is, and bringing in all these different fields, like, you know, the scientific knowledge, and then bringing in artists and making sure that they understand what the aim is and who we're trying to reach. I think it's really important that everyone is on the same page about that in order to attract the audience that they need. And yeah, and then also doing the research beforehand as well.
Thank you. I suppose before we round off this panel, there was something that really, I don't know about you, that struck me from Stephanie's presentation, which was, you know, the opening statement, chick what? And whether something that's come up kind of regularly is this notion of the names of the diseases. So it reminded me that, for example, the Schistosomiasis Control Initiative did toy a few times with whether they should change their name. Is this a barrier? Is this or not? And well, they're on Limit Health now, so that question has been resolved. Again, chikungunya, a lot of these diseases, and in fact, even the NTD, the neglected tropical diseases umbrella, on the one hand works wonderfully in terms of advocacy, but at the same time, do you feel that more could be done to simplify how we communicate about these diseases. How personally, I live in the global north, and it seems to me neglected tropical diseases, people will just hear rare disease that doesn't affect me. They're not rare, as we all know. So yeah, it was just a question about the language, and maybe just behind that, the brand, as some academics have started to call NTDs. Do we need to rethink this brand to engage communities? Is it fine as it is? It's an open question. I don't know if specifically thinking about engaging communities on these diseases, whether we need to change anything.
Well, because from where I live, where I come from, we have many of these diseases around here, and even scientists, they really talk about it, and even the medical communities, they have priority diseases, and but when we look at less, and then we know that once some people are neglected, then it's to the disadvantage of everybody. And so we need a powerful advocacy at all levels to talk about this. We need to engage the media. And one thing I think that I can champion in my country now is to talk about NTDs to the media, of media we are training. And then they need to study. We can even give some of them as assignments to research and work with experts who are from this area. And I know Professor Lucas is late now. He was working on Nigerian tropical disease, was one of my mentors. So if we can get people like that and they start writing about this, even political decision makers will start asking questions. What is happening here? And this is closely linked to universal health coverage. It's also linked to SDGs. So if they can start highlighting these linkages, if you're not addressing the entities, we said goal 3 of NDG said everybody should be healthy. Is it health for all, and then health? I can't remember what goal 3 said, but it's talking about health for all at all times, for all at all ages. So, and that means if some people still suffer this disease, then that goal is not achieved. So we need media, we need advocates, we need champions who needs to start talking about it. And we need new interventions, new approaches, and we need integrated approaches. Until everybody sees it as our problem, then I believe that we begin to champion resources, attention, and the collaboration that we really need to address this. I think that's one key thing I would take away from it.
And yeah, and thank you for highlighting the role of the press and journalists. We had a really great panel yesterday. The recording will be available for anyone who missed it, and lots of the ways in which that sector can really facilitate communication about these complex diseases. So thank you for bringing that up. Would anyone else have comments to add? Have we got the brand right? Obviously, those who work with local communities, there's lots of other words and lots of other ways in which these diseases are spoken about.
I feel like I can speak as someone who works in communications. I've noticed that there are some people who actually get confused with like schistosomiasis and Bilharzia, and they've thought that they're two different diseases. So, I mean, if people on our level are getting these names wrong or like getting confused with these names, I wonder how some people who actually have the disease, like what they classify it as, and if they're also confused about the kind of terms to use.
That's a really interesting point. Yeah, I did not know that. Lauren, you were going to add to this, I think.
Yeah, and I just kind of wanted to highlight, this is why it's so important for like Gabrielle's comic to be translated into local languages. It's fair enough having a brand everyone, and like NTDs is almost easier to recognize than having all these different names like Gabrielle picked up on, like schistosomiasis and Bilharzia, often complicated. And I think it's getting more attention, like recently in the UK government, NTDs was mentioned, which was getting there. So I think like other people were saying, it's super important to have it in the media and vocalized as well.
Fantastic.
Yeah, maybe if I may add, just with the caveat that using tropical might be confusing as well. I mean, I discussed recently with someone deeply involved in arboviruses, and he said that when he started his career, he wanted to work on in tropical medicines. And in the end, today, he says it's not tropical anymore. I mean, it's spreading with climate change, with global warming, and so on. So maybe this is something that is changing. Currently, tropical, we might think that's not a concern for a lot of people, but in the end, is tropical really appropriate for some diseases? So I think this is something we can think about indeed, because what is tropical medicines today?
Yeah, that's for sure. Oh, that's a really good point. Thank you. And there's never enough time to kind of cover all of the things, particularly speaking about community engagement across all these, neglected tropical diseases, which is the main focus of our festival. So before we leave, we did have one question in the audience for you, Lauren, from Rod Dillon. Rod says, Lauren, love the idea of the black bag to include soap and medication. Was that an idea from the feedback?
I believe the idea was from our program manager, Betty, but that was definitely based off the fact that the communities wanted confidentiality, and that was her kind of innovative idea to keep that confidentiality when giving out medications. Yeah.
That's a great addition to the program. Well, if there are no more questions from the audience, and thank you so much, because we've gone over time and you've already given us a lot of your time this morning for this panel. So unless there are any... Yes, Gabrielle.
I just noticed a question that was asked like before by Lillian. She just asked if the comic book was available in local languages, and it is available in Shona and Swahili. Those are the only languages that we have at the moment. So
thank you, and sorry about that, and I hope I haven't missed any other questions. If so, please let me know. There was a question about if these sessions are recorded, which they are. Please feel free to go to our YouTube channel for festival recordings, but also lots and lots of resources about chikungunya, on other approaches to controlling Bilharzia, schistosomiasis. So just a really wide and eclectic range of resources. Yes, thank you for spotting that, Gabrielle. Okay, well, if there are no more questions,
before we go,
yes.
Yes, I just want to ask colleagues in the room, what's your experience with stigma associated with these diseases? Could that be a barrier, and are we addressing that?
Absolutely crucial question when engaging communities. I suppose, Gabrielle, Lauren, you've been directly in the field working with some quite stigmatizing conditions. Perhaps you have comments for Dr. Yahya's question.
Yeah, I think stigma could be an issue, and this is why, again, it feeds back into why community engagement is important and repeated health education. I think having people local in the area to do the community engagement, so I know a lot of other people use village health teams as a strategy for engagement to have that trust and relationship. But yeah, I think especially like if the CDC keeps putting out information to make it more normalized, to show that, like Gabrielle was doing, that it's not witchcraft, it is a disease that can affect anyone. This is going to keep working against the stigma.
So it's a big issue.
Yeah, well, when we were when we had our Affected Voices meeting in Tanzania, a lot of people did bring up the fact that they are stigmatized, and they don't feel like they get enough support, like psychological support. So I don't know if the community health workers are equipped to deal with these the psychological aspect of their conditions, but they are trusted members of the community. So yeah, I feel like they're the best people to talk to about the stigma around these conditions.
So one last thing I would just like to say is, I think the society can consider this, because once there is stigma, people go underground. Nobody wants to declare they are having this. And that would be difficult for us to control, no matter what resources we put in there. So, and even people who have suffered it, who have been treated, who have received care and support, they can be vanguard, they can be champion, they can start sharing their experience, and to encourage other people who may want to come and still look at from communication response. Thank you.
Thank you. You've reminded me of a really great example that we had at the festival maybe a few years ago now, and it's obviously on a scale that might be difficult to replicate, but if everyone remembers the TV channel MTV, so they have backed through the MTV Staying Alive Foundation a TV drama, and we were mentioning, Lauren, you brought HIV into the conversation, and through this TV drama aimed at young people, it kind of role played things such as going, some of the main characters go to get tested at the HIV clinic, auntie sees them, what happens next? And it was kind of nice having those scenarios lived through the characters on screen, so that at home, anyone who felt a bit stigmatized or didn't want to engage with certain health processes already saw it unfold in front of their eyes. And subsequently, this approach got validated by the World Bank, etc. Anyway, sorry to go on a tangent, but I thought that was a really clever approach to sort of get people familiar with what might happen in their condition, or some of the steps they might go through to be able to access and engage a lot more with the healthcare system. And film, always a very important tool in communicating these issues. Hang and Stéphanie, dengue, chikungunya, which are some of the main diseases you've been working on, unless I'm mistaken, less of a stigma. Is that something that you've had to think about? I'm not sure who wants to go first. Whether
it sometimes makes me confused about neglected tropical disease in my area. Maybe also about dengue is included in that too, because in some area, like in Vietnam, dengue is really popular, so many people know about it, and we try a lot to control that. So it's actually not really neglected. And also it really depends, because in Vietnam, the community don't really, or even the scientists, if we don't work on that, we rarely heard about neglected tropical disease. Yeah. And I think that like because of that, people just know about a specific type of disease that really rarely happen, but not in the general term about that. So I think when we do the projects related to that, we need to point out the specific disease, not the whole terms of that, to make it easier to understand.
That's a very good point. And yes, and just the sheer numbers in outbreaks affecting so many people, I guess individuals feel less isolated in terms of their infection or the disease they've contracted. Stephanie, would you like to add any final words to our discussion before we close, bring this panel to a close?
No, I do not have a lot to add. Indeed, for chikungunya, as you mentioned, it's people are not isolated at all. When there is an outbreak, usually it's explosive, so it's a lot of people in the community who would suffer from this. So I don't think we have the same challenges as for other NTDs, but I mean, we still have all to work together, but challenges are a bit different indeed.
Yeah. And those are great words to end this session on. The road is long, but we can work all together. Thank you very much, Dr. Disu, for your question as well. That was a very important one in terms of community engagement. And just more generally, a very big thank you again to all our speakers today. You've given us so much food for thought, lots of very different examples on engaging different communities all around neglected tropical diseases. So thank you so much. A big thank you to our audience that's clearly been really engaged in the chat as well. So all that's left for me to do is to invite you to come to our next session. We will be talking with idiots. And by that, of course, I mean infectious disease specialists giving their opinion on through a podcast, through a very humorous podcast on infectious diseases, and also the WHO TDR's podcast, Global Health Unfiltered, and Immunology in Africa podcast. So a really fun, a really vibrant and exciting session coming up at ISNTD Festival. Please do jump onto the next link and join us for that. If you have to go, well, we look forward to connecting with you in future at another time. And especially to our panelists, let's definitely keep in touch. We want to know the next steps on all of your amazing work. And I hope we can have you very soon back here on screen at ISNTD Festival. But in the meantime, wishing you all the best and hope to be in touch very soon.
Thank you very much.
Thank you.
Thank you. Bye-bye.